us coming from the hub, loud and clear. My name is Koze Ziambo. Welcome to this afternoon's echo session, special echo session. And we are happy to yet again present something that will help us in this time of pandemic. This time we'll be looking at TB, TPT guidance during the COVID-19 pandemic. And to help us discuss this topic this afternoon, we'll have Dr. Patrick Lungu, the National TB NTLP Manager from Ministry of Health, guiding us through this afternoon. So please, you are welcome. We recognize everyone on the network. Thank you very much for joining us. And we do appreciate any comments, any questions at the end of this session, should you have any. And so without further ado, I'll also introduce my colleague that I'm with in the hub, Mr. Davis Kampamba. Yes, thank you, Davis. Yeah, and on the network, we have Dr. Patrick Lungu. Dr. Lungu, are you around?
Dr. Koze, I'm here. Good afternoon, everyone.
Thank you.
Good afternoon, Dr. Lungu.
Thank you so much. So, Dr. Lungu, you can introduce yourself and just discuss the initial objectives of this meeting, and then we'll move on to do the poll questions for the afternoon. Yeah. Kindly go ahead.
Yeah, thank you very much, Dr. Koze, and everyone who's been involved in preparing for this event. And I'd also like to thank the audience for joining in this important session. I think all of us are aware that globally we are facing a pandemic, and this pandemic is that of COVID-19, and Zambia has not been spared. And there have been measures that the Ministry of Health and the nation at large has put in place to combat or respond to the COVID pandemic. And some of these measures are meant actually to protect everyone, that's the nation at large. However, with the new measures, we also need to make adjustment in our programming so that with the needs of the programs and that of the nation in terms of protecting everyone from the COVID infection. So we're going to go through 4 main objectives in this session. So they essentially would like to outline the similarities and differences between TB and COVID-19. As you are aware up to now that in terms of the symptomatology of two diseases, there's quite a lot of similarities. So we'd like to explore the differences and also go through some of the similarities. Then our second objective is to explore opportunities that are existing to fight both diseases. Third is to explain the operational guidelines on service delivery for TB in this as we respond to the COVID-19. Then our last objective is to go through the TPT contagious plan. So TPT equally has not been spared. So by all means, we would like to continue the TB service delivery starting from diagnosis, treatment, as well as prevention, but we will need to tailor our measures or interventions in these 3 areas, bearing in mind the COVID response strategies that the nation and the ministry has put in place. So to start with, we have a poll question. So this is one of the patients that we've had. So our patient X presents to your facility with a cough, fever, night sweats, and chest pain. You as the attending clinician or nurse, you collect sputum and you also order a chest x-ray. Results from the lab and that of the chest x-ray confirm that this patient has TB. So during this period of the COVID-19, how many months of anti-TB medicine will you prescribe for this patient? So we'd like to start getting responses to that. Dr. Koze, you may guide on how we go around this poll question number 1. Dr. Koze?
Thank you so much, Dr. Lungu, for those introduction remarks. And to the network, you're welcome to actually pick your best answers from the given poll question. Thank you very much. And so, Dr. Lungu, just checking, we see that we cannot see your face. You're having a bit of a problem with network?
Are you able to see me now? Or let me start my video. Thank you. Let me start. I've started my video now.
Yeah.
I guess you're now able to see me, right? Thank you.
I think so. This will give confidence to the listeners that
Okay,
they
great.
know who's talking.
Thank you very much. Thank you. And sorry to everyone that I did not activate my video.
No, it's fine. It's fine. Thank you. Okay, so we have people. We're inviting you to participate. Can either pick. I know most of us may not be aware, but this is just to emphasize that is one of the take-home messages for this actual presentation. So kindly call.
Yeah, so as people are also choosing the answers or tackling the poll question, I'd like also just to re-echo that early last week, if not this week, we had actually sent out a memo that is guiding on how we respond to TB amidst the COVID-19. And this session essentially explains what is contained in that memo.
All right, thank you very much. So I'll end the poll. We move on to the next poll question.
Yeah, so our second poll question is a different patient. This is patient Y. This patient has been on ART for 2 years, and he was started on TPT, that is INH and B6 a month ago. So he's been on INH and B6 for a month now. He presents to the facility for his review. How many months of INH plus B6 would you prescribe in this clinical visit? So our first choice, 1 month. Our second choice, 2 months. Our third choice, 5 months. And our fourth choice, 3 months. So we'd like to get some responses to the poll question number 2 and 1. Dr. Kozia, I'd like you to guide the audience on how we proceed with the poll question.
Okay, so thank you so much. We can feel free to pick on those polls that have been launched and what we think is the best answer. If you don't know, it's fine, because we've come to learn. Thank you very much. So patient Y has been on ART for 2 years. He was started on TPT a month ago. He presents to the facility for his review. How many months of INH B6 do you prescribe? Very, very important. Okay. So far, we have about 112 connections, and I hope we are practicing social distancing. Very, very important for us.
Actually, Dr. Kozia, now it's called physical distancing.
It's called physical distancing.
Exactly. So
okay. We are
that's the
learning a lot of.
exactly. Yeah, so social distancing, you could still be in contact with people by phone and other means, like we are actually interacting now, but what's just separating from us is we have a physical distance between, we are separated by the physical distance, but socially we are interacting.
Oh, I see.
Exactly.
Becoming more.
Yeah, so that's the semantics of this period. So perhaps, Dr. Kozia, we could proceed to the next slide, given that we have 1 hour.
All right, thank you so much, everyone, for polling. We will be able to find out what the correct answers are as we proceed. So Dr. Lungu, please continue.
So just to help us to move together, we have two definitions. So I'd like to go through the definitions of what is now called the COVID-19. So essentially the COVID-19 from the clinical side and the scientific side, this is a novel coronavirus which was discovered in the year 2019, and it causes a severe acute respiratory syndrome. So that is caused by coronavirus 2. So in other ways, this is referred to as SARS-CoV-2. And novel in the sense that it's a new virus. It's never been discovered or documented ever before. And I think the definition for tuberculosis, we are all very much aware, this is a respiratory condition or a condition caused by bacteria called Mycobacterium tuberculosis. And it's been known since the year 1882. So this TB has been with us for many centuries, and it was discovered by Robert Koch. So we have a lot of history to talk about with TB. COVID is a new disease on the block, however, causing a lot of lives being lost. So just to take us through, there are a lot of similarities between the two diseases. Both diseases affect the pulmonary system, though TB can actually go extrapulmonary, meaning it goes beyond the lung parenchyma. Just to also go through the medium of spread, TB generally is strictly an airborne disease. With COVID, yes, we've heard a lot of mediums in which it is spread. One is through the medium of air, and also it lives on surfaces as well. So I think, to be on a safe note, COVID is spread through droplets. If we limit it to airborne, we will be restricting other means that it is spread. Remember, this is why we are washing our hands and also sanitizing surfaces, because these droplets can live there. And when we get in contact with surfaces that have been contaminated by COVID-19, and we touch our nose, our eyes, and our mouth, we get infected. So the medium of spread for COVID is droplet spread. That encompasses all the various means in which it is spread. So in terms of the symptomatology, to a large extent, TB presents with fever, cough. It could be dry, it could be a wet cough, and usually characterized by weight loss, poor appetite, drenching night sweats, and chest pain. These are very, very common symptoms and classical symptoms of TB. With COVID-19, the defining symptomatology is that of difficulties in breathing, cough, a dry cough, usually a sore throat, and fever as well. So one of the things that is actually may distinguish the two diseases is that COVID has a very short history. In terms of the symptomatology, you find that the symptoms evolve very rapidly and the duration is very short. TB also in certain settings could run a short course or a rapid progression, especially in children, but that's not very characteristic of TB. So that is a distinguishing feature between the two diseases. How is it diagnosed? To a large extent, TB is diagnosed from sputum. And also we have now other means like urine and the like. And also we have the clinical means of diagnosing TB. I'll not go into those features, but I think to a large extent, COVID now, we have a nasal swab. That is where we are collecting our samples for diagnosis. Yes, sputum could be used, but to a large extent is a nasal swab, a deep nasal swab. That's where we are collecting our specimen. In terms of the pathogen, as earlier mentioned in the definitions, TB is caused by Mycobacterium tuberculosis complex, MTBC. COVID is caused by SARS-CoV-2. In terms of the infectiousness, I think we have a lot of unknowns about COVID-19. But what is emerging so far with the information that we have, that one person is able to infect the next 2.2 patients, almost 3 patients, but this is evolving. I'm sure later on we may actually learn more about it, but I think so far with the given information, one person is able to infect 2.2 other persons. With TB, one person is able to infect at least to a minimum of 4 persons, and these are usually close contacts. Similarly, with COVID-19, it's usually spread to people who are close to these individuals. So they are both diseases transmitted through contact. In terms of prevention, to a large extent, TB, we have the preventive measures for TB and COVID. Some of them are very similar. Physical distancing also prevents TB, and it does also prevent COVID-19. But there's one distinguishing feature about TB, is that we have a TB preventive therapy, the TPT, and this is not in existence for COVID-19. I think both diseases require good hygiene. Cough etiquette is required for both diseases to prevent the disease. In terms of treatment, TB is curable and at the same time preventable. For COVID-19, I think it's preventable. At the moment, we have no cure. The treatment that is there is all supportive care. Chair, we could move to the next slide. So those are the comparisons and similarities between the two diseases. So what are the clinical differences between, sorry, we could move to the previous slide. So there are clinical differences between the two diseases. Some of them I've already mentioned. I think what is outstanding that we should know is that TB runs a chronic course, COVID runs an acute course. So the symptoms evolve very rapidly in COVID. With TB, months, weeks, and months. With COVID, it's days in terms of how it evolves. So essentially, I think things to take home: TB is a chronic disease, COVID is an acute disease. Though TB could also be acute in certain settings like children. So I also want just to take you through, because I understand there are clinicians on these platforms and nurses. Radiologically, there are some differences between COVID-19 and TB. So these are the things that we know for now about COVID-19, that this is a disease that affects mainly the lower zones, and it's usually peripheral. So when you look at a chest X-ray, be it a CT scan or chest X-ray, you find that the lower zones are the ones that are heavily affected and usually peripheral. With TB, it does not really select the peripheral side. It may be across all the lung fields, or usually closer to the hilar regions and the apical regions. Those are the typical features of TB. Though in HIV negative, TB could affect the lower zones, but it will not for sure concentrate on the peripheral sides. So far, there hasn't been any medial infiltrates observed in COVID-19, but with TB, this is a characteristical feature, especially in those who are immunocompromised. Effusion hasn't been documented in COVID-19. In TB, this is a very common feature even in our settings. In COVID-19, I think cavitations have not been documented. In TB, cavitation is characteristic of TB. On chest X-ray, what is so characteristic of COVID is that of a ground glass appearance, and usually in the lower zone and peripheral. And it's an early feature. So you could actually order, there are some X-rays that have been seen to be normal, but when they did the chest CT scan, they actually found that these individuals had the ground glass appearance. So radiological features is quite helpful in diagnosing COVID-19. In TB, ground glass is not a typical feature, and lymphadenopathy is not a defining feature so far for COVID-19 from the data that is being reviewed. But in TB, hilar lymphadenopathy, that's characteristic and defining of TB. In both diseases, chest X-rays may be normal. But one thing that of note is that the progression or deterioration in the X-ray features in COVID-19 are quite rapid. I was reading in one paper where in the morning, the X-ray was normal. By the time they repeated in the evening, the X-ray was so characteristic, and also the chest CT scans also had ground glass, extensive ground glass appearance. Yet in the initial phases, it was normal. So the progression is quite rapid in COVID-19. With TB, it runs a very chronic course, as earlier mentioned. So slow progressing in terms of the radiological changes. Thank you. Next slide. So these are some of the features that I picked up. If you look at for COVID-19 day 0, mostly affecting the lower zone and is bilateral. As the days move, by day 4, it starts to affect the middle lobe. By day 7, the disease has extended to all zones, so it's quite rapid. On the far right on your screen, you'll see that's a typical feature of TB. You can see on the diaphragm, sorry, I didn't put arrows, there's tethering of the diaphragm. So TB runs essentially, there are fibrotic changes with TB, and you don't see fibrotic changes in COVID-19. And if you look at the X-ray for TB, you'll see that the apical area is affected and the lower zones are spared. So those are the two distinguishing features of the two diseases. There are many X-rays that you can look at. And if you even look at the chest X-ray for TB, you'll see that there is widening of the mediastinum. That's the lymphadenopathy that we talked about earlier. So you could actually see the characteristic features of TB, which are not existing in COVID. So radiologically, we can distinguish between the two diseases. And also things to note, rapid progression, don't forget that. And of the radiological features, rapid progression of the symptoms are quite characteristic. Thank you. So I think now we are zeroing into the topic of the day. What will be the impact of COVID-19 on the TB program? And also I think this is quite relevant to the HIV program because there's quite a lot of TB, HIV co-infection. So we should all be concerned from both fronts. So I think of note, I'm sure you've seen quite a lot of stigma associated to COVID-19. And with this, and also a lot of fear, I think you can sense the fear that is out there, that people are afraid of contracting COVID-19, obviously rightfully so because it's a very deadly disease. But also this may affect patients who have a cough, and this may not be due to COVID. They will tend to withhold the symptoms and stay at home. And what this will lead to is that these individuals will continue spreading the disease, TB, in the community and in their households. And also we are likely to have poor outcomes of treatment because the disease for the TB disease will be advancing. Then also what we don't know is how will COVID-19 affect TB patients? There are indications that COVID-19 may severely affect TB patients. The reason being is that these are individuals who already have pre-existing lung damage. So with a super added infection of COVID, they're likely to easily deteriorate to an acute respiratory ARDS, which may lead to death. So this is why we are concerned. We may record poor outcomes in patients with TB who were able to cure should they develop COVID-19. And also going back to the cough, I think we've looked through the symptomatology being so similar. So this also brings in the aspect that as we let's also bear in mind, ask about symptoms and the shortness of bear in mind on how we can distinguish the two diseases. Then with the lockdown in some countries, we may experience drug stockouts, and not only stockouts of drugs, but other essential commodities. Masks, as you have seen, there's a widespread use of both surgical and N95 masks, and these are quite cardinal as we respond to TB post the COVID outbreak. So I just want to bring to the point that we may experience stock out of drugs should this outbreak prolong maybe even the few months and the like. Physical distancing measures and national quarantine measures may interrupt TB treatment in that some of the patients may not access the TB services. And it is the reasons that's why we are making some of the adjustment in how patients attend their clinical visits. Then also, we do not want to have congestion in facilities, because wherever there's congestion, there's a high risk of spread of COVID as well as TB. So lastly, I think to take note, with interrupted TB services, there's a likelihood of an increase in mortality and poor outcomes to TB as well as HIV as well. So the operational guidance, given this background that I've shared with you, that it is critical that we minimize the visit to the health facility by TB patients during this COVID epidemic. And it's for the reasons that we've mentioned about. We need to protect the TB patients from catching COVID, and also should also themselves contract COVID from spreading it around. It's equally critical that we avoid interruption of TB diagnosis, treatment, and prevention as we respond to the two diseases. Last, it's also important that we designate sputum collection points during this period. So within facilities, if you have sputum collection points, those are points that we should emphasize, that patients give or produce sputum from away from the rest of the patients. Why? We'll be protecting other patients from both diseases in an event they have COVID as well. Then also we'll be protecting other patients from catching TB if they produce the sputum away from everyone. So where there are no sputum collection points, let's ensure that we designate and establish these points that we start patients collect, where patients can give out their sputum from. Lastly, I think on this slide that it is very critical that we avoid stock out of commodities, because we do not want an interruption of the TB services starting from diagnosis to prevention. So we'd like now to zero in into how we manage drug-sensitive TB in this period. So before this epidemic, before this pandemic, we were monitoring TB, drug-sensitive TB patients more frequently. So patients were coming even up to 8 times or 6 times in their intensive phase. But now we would like to extend the period to 2 months. So if a patient is stable enough, give them drugs for 2 months, enough for their intensive phase. This is a guidance that we are providing now, and we like everyone to abide by it. But what is critical is that we also do not forget the monthly monitoring. So as a patient, if a patient comes today and is stable enough, we give them 2 containers and we label them for month 1 and for month 2. So month 2, they're not coming for their clinical visits. It's a very short visit. At the end of month 1, they're just coming to drop off the sputum. And they should also go home with a lab form. So they should, at the start, they should go home with 2 lab forms. 1 lab form for month 1, 1 lab form for month 2 for their sputum. So the sputum for month 2, they will drop it off as they come for their end of the intensive phase at their clinical visits. So essentially with this measure, we are reducing their visits from 7 visits in total to 3 visits, if not 8 visits to now 3 visits that they will have during the entire period. So this is what we are giving. So patients who are in their continuation phase, we need also to give them 2 monthly. So this is how the schedule shall look like. What is in blue? That's the current schedule. So it starts week 2, week 3, week 4, week 6, week 8, then we go to month 3, month 4, month 5, and end of treatment, month 6. So now in this epidemic, we are making an adjustment. And this is how their schedule shall look like. So obviously we have a starting point. Month 1, we are only expecting them to drop off the sputum. Unless they are unwell, they are not responding to therapy, they have an acute condition which requires a clinical visit, then they can actually call in and they will be attended to. Month 2, this is where we're saying if all being equal, they are from start, their clinical visit is at month 2. And at this month 2,
Dr. Lungu, just sorry to interrupt you. I think there are some complaints that some people can't hear. Chatonda, just do a quick check of the network. If people can hear Dr. Lungu, please let them wave.
Yourself, Samba, are you able to hear me?
I can hear you perfectly fine, but I've even received pictures that are showing that you are on mute that side.
So actually, we did a sound check, Dr. Sombo, and I think most of the connections actually did have sounds, unless some connections have not connected very well without using their audio devices. Yeah, so perhaps according in their facility base, they could just check that. Thank you so much. Dr. Lungu, can kindly proceed with your presentation. Thank you.
Yeah, so essentially what we're doing now is that we're reducing their visits to 3 clinical visits. That's at the starting month 2 and month 4 and at the end. And in month 4, they're expected to submit sputum and also submit sputum at exit as well. So I think we can move to the next slide. Yeah, so I think with drug-resistant TB, I would like to say that in the first 2 months, we're not making much adjustment for the reason that patients are on linezolid, and patients on linezolid may experience bone marrow failure. So we'd like to monitor the response or the adverse effects that are likely to happen to the bone marrow due to linezolid. So on this account, we'll maintain the regular visits for the next 2 months until we exclude bone marrow or they surpass the 2 months. Thereafter, we'll be moving away from the every month visit to 2 months. So essentially, only patients who are the intensive phase and within their 2 months of treatment will require to go through the normal schedule of week 2, week 4, week 8. Those who have passed month 2, let's give them enough drugs to cater for 2 months. So we are extending the review period for patients who have passed through month 1. The other reason is that patients are on bedaquiline as well. We need to exclude or monitor for prolongation of the QT interval, and this is likely to occur in the first phase of treatment. So after the first 2 months, it's every 2 months. And it's because of the many adverse effects. That's why we haven't made a lot of changes in the first 2 months for DRTB. So we could move to the next slide that shows how the clinical visits shall look like. So in the first phase, we're not making any adjustments. In the second, it's after 2 months that we're making adjustment. We're moving away from the monthly visits to 2 months until they complete treatment. So now patients who have passed month 2, it will be every 2 months. Next slide, sir. So there will be patients that may become unwell while on treatment. So one of the things that we are advising is that these patients should actually get a phone number of the facility. And before they leave that facility, before they leave their home, they should actually call the facility to say, I've developed a cough. So there are some people who may develop a cough which had subsided. So part of those reasons could be that they've actually contracted either a pneumonia, and that pneumonia could be due to COVID. So we'd like to take a lot of precautions on that. And this is why we're saying that they should actually call before they leave their home, and they will be advised by the facility. So they should also be expected so that upon arrival or they are picked from their home, so that the appropriate infection control measures are put in place. And also we are encouraging that we should actually, where possible, we should actually call patients to check on how they are doing. So when these patients who become unwell are on TB therapy, it is quite unusual, but it also does happen that we should make sure that we screen them for COVID, especially if there is a recurrence of cough or fever, and this should be done at triage. So what type of support that we need to give to patients? I think this I've already mentioned already that for TB, traditionally we've provided community healthcare workers who are at community level, who work as TB treatment supporters. So some of these TB treatment supporters, and this includes the MDRNSs, there is indication that we are going to pull them off. I think the discussions through the TBTWG is that we withdraw the MDRNSs, and we're just waiting for the PS to give final guidance on this issue. That guidance may even come out today or tomorrow. But what we do now in the interim is that we should encourage that we set up treatment support within the household. So the next of kin will need to be brought on board, educated about TB, educated on what they need to do. And this is that in this particular time, let's provide adequate information to our TB patients, both verbal and written as well, on how they should take care of themselves and observe their therapy. Where resources allow, let's leverage on telephonic or clinical follow-ups, as well as counseling on the expected review dates. So let's check on our patients through the mediums of communication, such as phone calls that we have at the moment. We had a discussion in the morning that we can leverage actually on the existing opportunities from the HIV community. Some of the patients that we have are actually co-infected with HIV. So the support that is there for HIV can be extended to TB patients, because it's the same patients that we are actually serving. So let's ride on the existing opportunities in our facilities and districts to actually call these patients so that we provide the adequate support to these patients. Now coming to the fourth objective, which is TPT in the era of COVID response. This is one intervention that we should not drop off. We've made a lot of gains in TPT. So I want to be very categorical in the guidance. I think we did receive guidance, appropriate guidance from the HIV, where we are extending the ART dispensation to 6 months. I think that's a noble call, and we support that from the TB program. And we're involved also in some of those decisions that were made. So the guidance that we've agreed from both HIV and TB is that the TPT dispensation also follows suit with ART. So this is where now we are saying we've looked at our commodities. We may not cater for all the 110,000 patients currently on TPT. So this is why what we're saying is that at least for now, we have enough drugs to cater for the ones who are currently on TPT. And what we're saying is that we prioritize TPT completion. So patients who are currently on TPT, those are our priority patients. So we make sure that we provide adequate drugs for them to complete. For example, if a patient is in month 1, in their current or the next visit, we make sure that we provide enough drugs for them to complete the 6 months. Similarly, same patients who are in month 2, we give enough TPT drugs for the additional 4 months. So there's an exception to the rule of new recruits. The TPT SAGE sites were provided with enough drugs to cater for 6 months of the patients that they had at the beginning of TPT, at the beginning of the TPT SAGE. So those can continue recruiting. We have enough drugs to cater for those. But the rest of the sites, let's prioritize those who are currently on TPT so that we do not fail them from completing. This instruction will be revised as things evolve. We're expecting some newer commodities, but remember that we're in this COVID response. there is restriction on flights. So we anticipate that some of our the deliveries of our essential commodities for TPT may be delayed. And so in order to mitigate patients running out of drugs, let's prioritize those currently in care. And facilities, you will receive further guidance on some of the things that you can do to actually anticipate or estimate your needs in terms of commodities. So you need to look through how many patients are in current in care and which month are they in. Then from there, you can actually quantify the commodities that you require and make orders so that you do not run out. Thank you. Next slide. So the other aspects, I think infection control is very cardinal in this period. I would like to encourage everyone to observe physical distancing, not only for ourselves, but also the patients that we are looking after. So as patients come in our facilities, let's ensure that there's physical distancing, and also the personnel working in the OPD, let's triage coughers. So let's identify people who are coughing in OPD, and quickly we take patients, we collect sputum, we take a history, and if it fits that of COVID-19, we take the necessary measures required for COVID. If it's that of TB, we quickly make sure that they are screened for TB. We should provide surgical masks for all coughers in our OPD, in our wards, but also taking cognizant those who are in respiratory distress. Let's put in measures not to make them deteriorate further. So I would like to encourage patients in OPD to put on the protective gear, and here in particular, I'm talking about the N95 masks. So there has been some N95 masks that have been dispatched from central level through the support of ETB. They are purely meant to respond to protect healthcare workers from contracting the infectious diseases. And here we're talking about TB and also COVID. We cannot say to only protect TB, but COVID as well. So we like to protect our healthcare workers. This also extends to our staff in the lab as well. So let's avoid, in as much as we are promoting the use, let's avoid the unnecessary use of the N95 masks as well as surgical masks. Let's ration the usage so that we do not quickly run out. Let's prioritize the high-risk healthcare workers, those especially in OPD, the TB clinic, ART clinics, and the like. Next slide, sir. So in summary, I think now we are coming close to the end of my presentation. We are saying that TB services for diagnosis, treatment, prevention should continue in this period that we are responding to the two pandemic and the epidemic. We should raise awareness as healthcare workers on the two diseases. Let's work together to reduce the fears that are out, providing correct information on the two diseases. Enough information for our patients and the communities where we are. Secure enough commodities for the patients that you have at your facility, in your district, as well as the province. Let's create a schedule and calendar for patient reviews. This is very important. Why is it very important? This will avoid congestions, because if you do not have scheduled visits, you end up having a lot of patients coming in one day, and you will not be able to send them away. So by all means, let's create schedules for our patients and calendars for our patients so that we do not have overcrowding. Lastly, I just want to say that with all these measures, let's fully evaluate the patient needs and devise a plan for the patients that's before you. So this is the guidance that we are providing, but you can make adjustments in the guidance. There are certain patients who may require close monitoring, patients who may have already pre-existing organ damage, those with renal failure, those with liver failure, or undernutrition. Some of them may require frequent visits. So let's tailor the the plan based on the patient's needs, the ones that's before you. However, this is the guidance that we are providing for a large scale. I thank you all.
Thank you so much, Dr. Lungu. We do appreciate this guidance. I think it has given us direction in how we can proceed in offering care during this pandemic. And so I hope the network is now ready to ask some questions, but we will proceed by going through some of the polls. So the first poll question, I think we should pick so that we learn what are the correct answers. So patient presents to your facility with a cough, fever, night sweats, and chest pain. You collect sputum and ask for chest x-ray. Results from the lab and chest x-ray confirms the patient has TB. During this period, when there is COVID-19, how many months of anti-TB medications will you prescribe? So let's let's give our poll questions, and sorry, let's pick the best answer. Is it going to be 1 week, 2 weeks, 1 month, or 2 months of medication? So I see about 188 connections this afternoon, and we're hoping participation can be good. Yeah. So we can see that most people think D is the correct answer. So I'll end the poll here and then invite Dr. Lungu. Just give us which one of these is the correct answer.
Yeah,
Thank you.
For poll question number 1, the correct answer there is D. So like I guided in the presentation that for the intensive phase in this period, in the era of COVID-19, we will provide enough drugs for the first 2 months. So enough to treat the entire intensive phase. So D is the correct answer.
All right, thank you, Dr. Lungu. We'll move on to the next poll question. Patient Y has been on ART for 2 years. He has started on TPT a month ago. He presents to the facility for his review. How many months of INH B6 will you prescribe? Is it 1 month, 2 months, 5 months, or 3 months? We invite the network to put the poll in the questions, the answers for this poll. So let's pick an answer quickly. We are only remaining with a limited amount of time because we have to end the meeting the next 10 minutes. So I will end the polling just now and ask Dr. Lungu to run us through the correct answer.
Thank you, Dr. Kodia. I think I would like to appreciate the audience that I think they were paying attention. 79 chose C, 5 months, and that's the correct answer. So we will be giving supplemental INH and B6 for them to complete. So regardless of the duration that is remaining, give enough drugs to complete the TPT treatment duration. And this is aimed in achieving completion. And most of these patients are already on ART. Our TPT intervention at the moment is mainly in people living with HIV. So the ART is already moving with 6 months. So it will be pointless or cumbersome and not patient-centered to have a separate measure for TPT. So both two needs to be aligned together.
Thank you so much, Dr. Lungu. I'm sure you've got some time to answer some questions. So we are going to invite the network to ask some questions. I already have about 3 hands, so I hope you've got a pen and paper, Dr. Lungu, so yes, that we can have questions asked in a row. So we are going to ask Andy B go ahead and ask your question. Andy B, please proceed and ask your question. Okay,
Yes, please.
Dr. Kakusa? Dr. Mwanja Kakusa, please go ahead and ask and make your comment. Thank you. Oh, please unmute yourself, Dr. Kakusa, and you can ask your question. Okay, we'll ask Weston Mwanza from the Copper Belt.
Okay, thank you so much. As mentioned, I'm Weston Mwanza. I'm coming from Copper Belt Province. Yeah, my question to you, Dr. Lungu. First of all, I have to say thanks so much for the nice and educative presentation. But my question is for TB sputum examination. Since in the TB program, I think traditionally we've been doing a sputum examination at month 2, going up there, depending on the results of the sputum that has been done at month 2. But during this period, are we going to be doing sputum examination even during month 1? I think that's my question, sir. Thank you.
Thank you so much. Before you answer, Dr. Lungu, let's get some more questions. Lutinala, there's a hand raised by Lutinala.
All right. Thank you very much, Dr. Lungu, for the wonderful presentation. My question is to do with the sputum examination in the laboratory. There has been a lot of anxiety from laboratory staff on whether the sputum also is, because of the nature of the coronavirus, whether it is also, they are also at high risk of exposure to the virus as a result of handling the sputum. I know you already mentioned that there's a lot that is not known, but I think it would be good for you to comment on what is the relationship between sputum examination and what is the exposure risk for laboratory staff. In addition, also, I think my appeal is that it would be nice to include laboratory staff on this platform, because I think they're also a major player in the control of TB. Thank you.
Thank you so much for those comments and questions. I will invite one more question from Sulani.
Hi, good afternoon, everyone. Thank you very much, Lungu. Mine was just like a general.
Sorry, we are unable to hear you. Can you just get closer to the mic?
Mine was a question, like, or a reaction.
Sorry, Sulani, we are not able to hear you very loud and clear. If you're having trouble, maybe you can type your question on the chat, then we can attend to it.
All right.
Thank you very much. I'll ask Mumba Ngoma to make a comment.
Thank you very much. Good afternoon, everyone. Thank you, Dr. Lungu. That's a very informative presentation and very helpful looking at what's happening right now in terms of the COVID-19 virus that has brought a lot of complications. My question to you, Dr. Lungu, especially when it comes to B6, which has been at times been problematic in terms of stocks, is it matching with the TPT drugs available? And then secondly, my question to you is, when it comes to diagnosis, of course, TB, the common one is sputum examination. And then you were saying for COVID-19, it's a nasal swab. Is it the secretions in the membranes that are collected? And
Thank you very much. Thank you very much, Dr. Lungu. You can, oh, you still have a question, sorry.
Yeah.
Sorry for interrupting.
Yes. Thirdly, my question is, how many people are on TPT? Or what I know, I need to be corrected. Is it correct that 412,000 people on TPT and we're ahead of the targets? And if we're ahead of the targets, what are the targets? Thank you.
Thank you very much. I hope, Dr. Lungu, you've picked those 3 questions that have been given to you. Kindly respond.
Yeah, thank you very much. I'll start with the one.
So just make the responses very brief, because we will need to end the meeting in the next 4 minutes.
Okay, great. So I'd like to respond to Weston's question. So Weston, I think the guidelines has been that with TB, we monitor sputum every month. And it's important that we monitor at month 1, month 2, so that we identify early those who are failing treatment. So we should not forget the month 1. And in this guideline, we're saying that they're just coming to drop off. So we should not forget the examination of sputum at month 1. It's quite an important measure. In an event, we may have missed the rifampicin resistance early enough, we can pick it up in month 1, and also it helps us to determine those who are responding to therapy. So month 1 is still critical, and month 2 as well. Lutinala's question on the lab, this has brought quite a lot of controversy and a lot of cries. So I just also I would have loved that Dr. Chamba was also given a chance to talk about, and Dr. Chansa. But I would like to give guidance that COVID-19 is a droplet infection. So to a large extent, when we are preparing sputum in the lab, there's very little manipulation. And we actually also add a lysis buffer. That lysis buffer is able to kill every living cell, and that may be that of COVID-19. So essentially, the take-home message, as we are running the Gene Expert, there is no aerosolization that is there. So one of the things that we should take care of is that we should sanitize the surfaces before starting to process the sputum and after processing the sputum. And also would like to encourage them also to wear N95 masks so that we are fully protected. So we should not stop running Gene Experts in this period. But however, we should maximize on all the preventive measures, sanitizing the surfaces before and after, and wear the N95 masks as we process. With regard to the stocks of B6, actually, Mr. Mumba, you note that actually we even have more B6 than the INH. So we have enough stocks of B6 to match up that of INH. So what we should just, facilities that are experiencing stockouts, quickly order, and where you have challenges, reach out to the responsible person. At the ministry, we have Morton, also we have Davis there who can help us. So we use these pharmacists to help you, and work also together with your provincial pharmacists. They're quite helpful. In terms of the targets, Mr. Mumba, yes, our numbers for TPT are increasing, and we did review our data, and it has shown that we are actually
a button which says join audio.
Actually, we are on course in achieving the UNGA targets. And this is why we are saying, let's not drop the ball. Let's continue marching forward with what we have achieved so far. And that's why we are making these adjustments, so that we remain on course amidst the challenges that we are facing. In terms of the 400, I cannot confirm that. We'll be reviewing our end of Q1 of 2020 soon, and soon enough we'll have verifiable figures. But in a nutshell, we are making very good progress with TPT. I think those are the questions I had, Dr. Kozia. And just to assure Lutina, I think the invitation to this platform included that of the lab staff, and I hope most of them did connect. Dr. Kozia, over to you.
Thanks a lot. Dr. Chabala, you want to make a comment?
Yes, I just, well, it's not a question, it's just a comment for the schedule in terms of the pediatric patients. I think we need to make a provision, especially for the ones below the age of 5 years. A 2-monthly interval may be too long, because they usually rapidly gain weight, and then we may need to adjust their dosages according to the gain in weight. So maybe we probably need to provide different guidance for that, especially under the older ones, they are ready and isn't so rapid.
Thank you so much, Dr. Tawala. I think that Dr. Lungu want to make a comment on that.
Yeah, I accept what Dr. Chavala has brought to the fore. I think that's what we need to do. Thank you.
All right, thank you very much. I would like to apologize to the network. I know this is very informative session, and then there's another meeting that's supposed to take off at 15:30, and so we had only given an hour to this session, and so we've exhausted our time. And I really apologize that we have not responded to all the concerns. I would like to commit that we are going to make a brief comment in the next meeting we're going to have next week on Monday, and we'll be able to just clarify a few things during that meeting. So we will have to end the meeting, and apologies again. Next week on Monday, when we meet again to make presentations, we'll also mention briefly on the issues that have been raised in this meeting today. I would like to encourage all those that these sessions are open to everyone. There is no limitation as to restriction to who is supposed to participate. So let's share the links. Once we share the links, share them out to everyone who will benefit from the information. And for those that would like to have the presentation, please do access this presentation on Slack. And then also note that we have recorded this session and it is on YouTube. So just look for MOH UTH YouTube channel and you will be able to see this presentation. I think that said, I would like to say thank you so much, Dr. Lungu, for this presentation, I think, and the guidance. And to the rest of the network and the team that we have in the hub, Mr. Kampamba, Madam Priscilla, Tatonda, thank you so much for being with us. And we wish you a blessed day. Have a good day. And stay safe.
Thank you.
Thanks, Kozia. Just to let the network know that the topic for next week is a literature review coming out of the COVID-19 pandemic. So we'll be reviewing all the data, all the papers, all the research, and saying what's true, what's not true, what we should follow, what we should not.
Yeah, then Kozia and Somba would like just also to say that we'll provide a written comprehensive guidance on what we have shared. This was a summary of what we are developing. So we'll provide additional information to this. Thank you.
Thanks, Patrick. That was great. Very, very comprehensive, very clear.
Yeah. And I think we'll contact Dr. Chavala for those adjustments in the dosing for the pediatric population.
Yeah. Thank you. Let's do that. Bye-bye
Right.
and free of COVID.
Right. Bye.
Bye.
Thank you. Bye-bye.
Job well done, Hab, Kozia, Davis, Madam Priscilla.
And sorry, I forgot to let.
Yes, for somebody.
Is that Mary?
Yeah, it's Mary. I forgot to let people know that our colleagues from Nigeria and from other Southern African countries also joined. I don't know if you noticed some colleagues from CDC Mozambique, from CDC Nigeria, but there are a lot of people who joined because this topic is something people are really grappling with. So thank you for hosting this in a timely manner. I'm sure they were happy to be on.
Thank you, Mary. We hope there was something, one or two things that they were able to pick.
Yeah, I'm sure.
Thank you from Mozambique.
Hi, how are you?
Hi, Mozambique.
Yeah, it's fine.
No, it's good to hear a voice coming from Mozambique.
That's good.
Yeah.
Even voicing from Zambia. Eh?
Yeah. It shows that we are still soldiering on, and we're going to
Okay.
overcome.
Yeah, we are in touch.
Well done, Tim. I was listening in.
Thank you so much, Dr. Kankasa. Oh, she was on there.